So I'm going to start by providing an overview, a national perspective of ACA implementation, and then I'll dive down and talk more about California's experience, and then discuss some of the pressures facing hospitals and the healthcare industry, and then where the industry will be heading in the coming years. So to start, let's take a look at the Medicaid and CHIP enrollment under the Affordable Care Act. So as we can see here, 11.2 million individuals have been enrolled under the Medicaid program since the enactment of the Affordable Care Act. Now, as you know, many states have the option to expand their Medicaid programs to individuals up to 138% of the federal poverty level. California was one of the states that very quickly embraced the coverage expansion provisions of the Affordable Care Act. But as you know, many states decided not to expand their Medicaid programs, and largely that was based on political reasons. So as we see here, the line on top, that shows the expansion in the states that have expanded their Medicaid programs. And as you can imagine, the bottom line here, the states that did not expand their programs, they haven't had as much of an increase in those states. So when we look at the uninsurance rate, it is at the lowest at 11.9% since the Gallup poll began tracking it in 2008. And what we see is it reached its peak at 18% right before the provisions went in place for the Affordable Care Act for individuals to have coverage. So after January 1st, 2014, we see the uninsurance rate decrease, and then we see it spike a little before the end of the first open enrollment period. And so we know that there were other factors here. We know that the economy was improving and the employment rate was improving. However, when we look at the uninsurance rate and along the same timeline as the enactment of the Affordable Care Act, many folks do think that the ACA has in fact contributed to the decrease in the uninsurance rate. This here shows the status of states' Medicaid expansion decisions, and as I mentioned, states had the option to expand their Medicaid programs. What's unfortunate here is that in those states that decided not to expand their Medicaid programs, they're leaving roughly 4 million individuals in a coverage gap, meaning that they make too much to qualify for Medicaid in their states, but they don't make enough but they make too much to qualify for the other ACA expansion provisions, so for the exchange subsidies. So they're in this coverage gap, and that means that 4 million individuals nationally could otherwise have coverage if they just perhaps lived a state over that did expand their Medicaid program. And this here shows the state health insurance marketplaces. So states have the option to either establish their own state-based exchange, which California did. California was the first state in the nation to establish its exchange under the Affordable Care Act. States could also partner with the federal government for a federal-state partnership exchange, and then many states just threw up their hands and said the feds could go ahead and do that, so they have a federally facilitated exchange in those states. So what we know is that under the Affordable Care Act, 11.7 million consumers have been enrolled through marketplaces. So those marketplaces are where individuals who earn up to 400% of the federal poverty level, they're eligible for those advanced premium tax credits. If they're up to 250% of the federal poverty level, they're also eligible for cost-sharing reductions to make the cost of their care even more affordable. And then individuals over 400% of the federal poverty level are eligible to purchase coverage in marketplaces if they don't have employer-based coverage or that's affordable. So many folks who were self-employed now have the option to purchase coverage through the marketplace. So one of the first tangible tests of the Affordable Care Act is really how affordable is it making coverage for individuals. So the Kaiser Family Foundation looked at the premium rate increases over the past year, and what they found was that nationwide, the premium rate increases were fairly moderate. We know that in California, on a statewide aggregate basis, the premium rate increases for the marketplace only rose by about 4.2%, which is in fact lower than it has been in the past. So this is leading folks to believe that yes, health coverage is becoming a little bit more affordable under the Affordable Care Act. And as you may know, the public opinion remains stable. So nearly 5 years after the ACA has been implemented, folks are still in the same range, with with 46% finding the Affordable Care Act unfavorable and 41% finding it favorable. And as you may know, this largely rests along party lines, which should be no surprise there. Now, when you ask folks, average consumers, about the Affordable Care Act and how much they know, Kaiser Family Foundation asked this question here about the individual mandate penalty. So were folks, did they know that if they didn't have coverage, there would be a penalty? And did they know what that penalty was? And we see here that 72% of the respondents, they either didn't know or they just elected not to respond. 3% of consumers had the correct answer for 2015. However, 6% they stated the 2014 penalty, which means that they likely didn't know that the penalty increases in years 2015 and 2016. And then we have the 19% their other. So this is really interesting because we're going to see how this plays out this first year, this first tax season under the Affordable Care Act. For the first time, individuals' health care experience is now tied with their tax experience. So that will have implications for individuals who maybe they received too many subsidies because Covered California didn't have updated data, and maybe they owe the IRS money. So this will be interesting to see what the consumer's experience of care is and their experience after year one of the ACA. Now, partisans are still divided on the future of the law, as you know. This here shows that roughly 24% want Congress to expand what the law does. 21% are fine with moving forward the way the law was implemented. 12% would like the law to be scaled back, and 31% would like the law repealed in its entirety. So this is not surprising that we'll still continue to hear debates on how effective the ACA has been for consumers. Now, with that national perspective, I'll move more to a California perspective. As you all may know, our state Medicaid program was very successful. California really led the nation in terms of ACA implementation by really embracing the coverage expansion provisions. So in terms of our Medicaid program, there are now over 12 million Californians enrolled in our state's Medicaid program. Roughly 1 in 3 Californians is now enrolled in our program. Our state's Medicaid program is the largest Medicaid program in the nation. It is twice as large as the second largest Medicaid program, which is New York. So this has huge implications, not only on providers in terms of reimbursement, but it has had huge implications from the consumer perspective. Consumers are reporting access to care issues. They're not able to seek primary care. They can't get specialty care appointments. So this is very concerning that more folks do in fact have coverage, but they don't actually have the access that they need to get services. And what hospitals have seen is that the demand for services has in fact surged. So this here shows that there have been an additional 200,000 acute care medical patients seen in hospitals and 3.6 million increase in hospital medical outpatient visits. And what the data shows is that those newly insured in Medi-Cal, they are in fact using more services than they were using when they were previously uninsured. When we look at the data for Covered California, we see that there was no measurable difference from third-party coverage to Covered California coverage, which leads us to believe that many of the folks who are in fact enrolling in Covered California either were previously self-employed or had employer-sponsored coverage. So as you all know, coverage does not equal access. As I've mentioned, the access issues are driving folks who are insured to emergency rooms because they don't have the access to primary care and specialty care. And this is very concerning. Another factor in this is the reduced payments to primary care physicians that was not extended past the 2 years that it was permitted for under the ACA. So we have some serious access issues, and while it's wonderful that there are many more folks that are covered. We just need to make sure that these folks can actually access services on a go-forward basis. With regards to the Covered California Marketplace, California had one of the most successful marketplace launches in the nation, with over 1.4 million individuals enrolled in the first year alone. Now, we do know some data about this first group of enrollees. About 80% of them went ahead and re-enrolled for 2015. 9 out of 10 of them stayed with the health plans that they had selected in 2014, and Covered California reports that they did some shopping around. They went online, they compared to see what was the best option for them, and 9 out of 10 consumers stayed with their plan. Now, through the second open enrollment period, we see here that roughly 500,000 individuals enrolled through the second open enrollment period. California and the rest of the nation actually extended the enrollment period. They created a special enrollment period through the end of April for consumers who, when they go to do their taxes, found out that they had a penalty and they didn't know that they didn't realize that they were going to have the penalty. So Covered California created a special enrollment period for those individuals to go ahead and then seek coverage through California without having to pay a penalty. And Covered California reported today that in the special enrollment period thus far, about 75,000 individuals have enrolled. 22,000 of those individuals reported that they did not know that they would have had a penalty. So those folks were able to then seek coverage through the exchange. Now, the financial impact to hospitals under the Affordable Care Act has been immense. Hospitals over the first 10 years of the ACA are bracing for $22 billion in Medicare cuts, and the cuts keep coming. And so the concern is, well, we have more and more folks entering the system, and we already are starting to see the access issues. We're not seeing an investment in resources into the system. We're actually seeing funds, being taken away from the system. So it's going to require hospitals and other providers to really look at providing care in a different way. And I'll talk about that in just a moment. So there's a lot of uncertainty that's next, and there's a lot of potential actions that we're still waiting on to really know how successful the ACA is and how it impacts consumers. So we're still waiting on the possible ACA target amendments that were included in the President's budget proposal. We're still waiting on the Supreme Court's ruling for King v. Burwell. The validity of those subsidies are provided in the federally facilitated marketplaces. And while California has a state-based marketplace, so that in theory wouldn't apply to us, it absolutely would have an impact in California because many of the health plans that operate in California also operate on a national level. So to the extent that they would be affected because the individuals in other states wouldn't have access to those subsidies, we would definitely feel that in California as well. We're still waiting to see the effect of the employer mandate as well as the individual mandate penalties, and we'll know more about that as we kind of come out of this tax season. And the impact of narrow networks. Now, historically, the market tends to correct itself a little after there have been narrow networks. They tend to widen a little bit. But we still need to see the outcome and to see if that really happens. Covered California has taken the role as an active purchaser, and they are very upfront about the fact that they have narrow networks. They're limiting the networks so they can keep the cost of care more affordable for their consumers. Also, the high out-of-pocket consumer costs. Covered California reports that an alarming amount of individuals are selecting the silver plans and the bronze plans, and those are the plans with the higher cost sharing for the individuals, higher out-of-pocket maximums and so forth. So consumers really need to be educated about the coverage options that they are selecting and to know where they will get the best bang for their buck. We do know that many consumers who are in fact eligible for those cost sharing reductions because they are under 250% of the FPL, many of them are selecting the bronze plans. So they're not actually selecting more affordable coverage. And so there's definitely an opportunity there to provide more education to consumers and more health literacy. The convergence of Medicaid in the marketplace. So Medicaid, now with 1 in 3 Californians on the Medicaid program, Medicaid is the largest purchaser of healthcare services in the state. And as we know, many individuals will churn between Medicaid and through the exchange. They will go back and forth as their income fluctuates. And so Medicaid and the exchange, along with CalPERS, will be aligning a lot of their value-based payment programs and quality improvement initiatives, and that will definitely have an impact on our healthcare delivery system in California. And then I also listed here in 2017, the states have the option to open their marketplaces to large employers. And so that is another area we're waiting to see. How many employers are going to put their employees in the exchange because it might be a better ROI for them. And we fully anticipate that many employers will in fact do that, and then many more individuals would be covered through our marketplace. So with that California perspective, I wanted to just touch on a few more pressures on the healthcare system. So here we see the national health expenditures, and we know that the U.S. spends about $2.9 trillion, or roughly $9,200 per person, on healthcare. And our country's spending on healthcare as a percentage of the GDP is roughly 17.4%. And that's not sustainable, even though we know that this has moderated over the past 5 years. We know that whenever the government is in crisis, they start to take more and cut more from Medicaid and Medicare. So this is very concerning for providers. Now, many folks are starting to look at health expenditures as a percentage of GDP compared to social services investments. And you see the United States there, we have some of the highest healthcare expenditures as a percentage of our GDP. Look at the other states. They make far more investments in social services, in old age pensions, in housing, in ensuring that their society is taken care of to prevent them from getting ill. And so the question here, and what many researchers are starting to question, is why the U.S. is spending more on healthcare, but we don't actually have improved health outcomes compared to some of our nation colleagues. So this is of interest to researchers lately. When we look at the hospital share of the healthcare dollar, we see that over the past 30 years, it has in fact declined. In 1980, it was 42% of 43% of the healthcare dollar, and now it has declined to roughly 33%. And if we look at the other categories, they're all roughly the same, with the exception of one category there, that red category, prescription drugs. Now, prescription drugs have probably helped to mitigate folks being in hospitals. They've kept people out of hospitals. They've helped individuals manage chronic conditions and so forth. But the question is, how do we expect that to look in another 30 years? We definitely think that the share of the hospital dollar will in fact decrease. But what other areas do you think will increase and decrease over the next 30 years? So that's very interesting to think about there. When we look at California's per capita costs, California provides care that is typically cheaper than the rest of the nation. And so we really need to give providers kudos for that, for keeping people out of hospitals, for providing care, and that's largely because of our integrated healthcare systems and providing coordinated care. And a lot of folks always ask, well, does Kaiser have something to do with this? And they do. And so I can't stress, but even if you remove Kaiser from the system, California would still be performing very well, but I can't stress enough the value of the integrated healthcare model. And we have some of the lowest utilization rates in the nation. So we are good at keeping folks out of hospitals. Now this here is the case mix index, and this shows how sick patients are. And as we can see here, patients over the past 10 years, they are getting sicker, which is very concerning because the sicker a patient is, the more expensive they are to treat, the more chronic conditions they typically have, and the more services they need. And this is really troubling when we look at California's population growth, and especially when we look at the aging population. So if you look at our population growth, we're on par with the rest of the nation. But when we look where the population growth is, we see that in some of the rural areas are where we're going to see more concentrated population growth. And this is troubling when we look at the next slide, which is the aging population. So here we see that the population over, between 55 to 65, will grow by 3%, but the largest rate of growth will be for the population over 65%. And this is concerning because as people get older, they get sicker and they are more expensive to treat, have more chronic conditions. And our research shows that this concentration is occurring in rural areas, which is very concerning, as you all know, because there are provider shortages, and there tend to be even greater provider shortages in rural areas. This here shows the incidence of chronic disease, and we know that for every 1% change in the incidence of chronic disease, there is a corresponding increase by 6% in utilization. So as folks are getting older and they have more chronic disease, they will need to access more services. And that's troubling because we look at our population growth and we plot it with licensed beds in the state, and we see that we don't have as many beds, and hospitals have been closing over the years, and so that's also very concerning as well. And this here, we took health status and we plotted individuals or areas where individuals have more than 2 chronic conditions, and we plotted that with where they lived and the primary care physician capacity. And it was really concerning because we found that in areas where folks needed care the most, they didn't actually have the primary care physician capacity. So that's very concerning, especially that we know in California, roughly 30% of our physicians are over the age of 60, so nearing retirement. And then when you think about the influx of the Medicaid population and how California has some of the lowest reimbursement rates for Medicaid, are those physicians really gonna, be able to stick around and continue serving this population? We don't know, so that's a big question for everyone. So what are hospitals doing to prepare? We recognize that population health management, this is today. This is the way the healthcare industry is moving. There's this recognition that we have to manage the health of our population. We can't just see individuals on a one-by-one basis. We need to understand what it needs to be a whole person care delivery system. And especially when you look at how expensive chronic diseases are, they account for 75% of our nation's healthcare spending. That's very troubling. So we have to manage the health of populations. Well, we also know that this is where the payment models are going. The Centers for Medicare and Medicaid Services recently announced their goal, but by 2018, they would like to have 50% of their payment arrangements be more value-based. And then after they made that announcement, a group of private purchasers said, well, by 2020, their goal would be that 75% of their payment arrangements would be value-based arrangements. So folks are definitely more interested in managing the health of populations, improving the healthcare quality, and achieving the triple aim as envisioned under the Affordable Care Act. And so what we will see is organizations take the role of a population health manager to help manage the health of populations. It's not always going to be a hospital, it's not always going to be a health plan, and in fact there are many folks vying for this role. You see the retail industry vying for this role, Walmart, CVS pharmacies. A lot of folks want to be that healthcare population health manager. And so what will it take to achieve that vision of population health management and improve quality, improved healthcare, and lower costs? It's going to take leadership. It's going to take buy-in by providers and other entities to understand that we need to work together to manage the health of our population. It's going to take stakeholder participation. It's folks reaching across silos, partnering, collaborating. We're seeing that with the recently announced Vivity model where 7 hospital systems came together and forged an alliance with a health plan saying, we want to work together to manage the health of our population because we see that this is tomorrow, and this is the only way that we can achieve the triple aim. And it's going to take folks working together on common goals and principles, and we are going to have to work within the framework of the reforms that are before us. I think many folks had hoped that the private market would have the innovation and would be able to make this change. And I think we're going to see a lot of this take place in the public arena as well as Medicaid and the exchange converge. Expanded coverage is great because now that folks are covered, we can actually focus on improving their health and well-being. And then lastly, it's going to take funding and other investments, so it will be an expensive endeavor. And so how we're preparing hospitals is we've developed a population health management program for all persons within the hospital, all levels of leadership, because this new model, it's a really new way of doing business, and there's business imperatives and clinical imperatives, and including persons and their families in discussions and improving their health. A lot of technology infrastructure is needed, and this is new technology, new use of data analytics to improve the health of populations. So this is how we're working with our members to ensure that they are prepared to provide the best quality care and to improve the health of their communities and to lower healthcare costs. So I'll stop there, and I'm happy to take questions during the panel session, but feel free to reach out with any questions afterwards as well.